Thank you so much for joining me today. I wanted to take a few minutes and do a quick revisit on kind of the key theme from the network, the national network annual meetings that were held in December. Not all of them, but certainly three important ones, and also talk about kind of what I think the impact might be of the discussions in December on things that are happening in TEFCA and how the other networks might be aligning with some of those new SOPs or standard operating procedures under TEFCA. So some of you may already be on TEFCA or be thinking about joining TEFCA or be on another network or be thinking about joining another network. So I'm going to be kind of diving into some of the new things that some new business processes that and talk about how that could sorry, my window working here, how that could impact the other networks. So in terms of our agenda, because we have such a large group today and a lot of things to cover, I'm going to ask everyone to just kind of do a quick welcome to the group in chat, introduce yourself, feel free to chat away in the chat. And we'll talk about the meetings in December very quickly, cover a couple of what I think are the most important new TEFCA SOPs that have come out in the last 6 months or so, and then how that translates into participant onboarding, because I do think there's going to be some impacts on existing network participation in terms of new participant onboarding due to some of these new SOPs. And also Carequality, I'm on the Carequality Advisory Council. We are currently looking at these and other TEFCA SOPs and thinking about which ones are relevant to Carequality, which ones should we be adopting or adopting in part to build trust. So I'd love to get your input as we go along. So for those of you who don't know, the National Network's annual meetings were in early December, and it was eHealth Exchange, Carequality, and the Sequoia Project, which of course the Sequoia Project is the recognized coordinating entity for TEFCA.
Marilee Benson's thing.
And I'm just curious, how many of you attended? And I don't know if there's hands up maybe that could be put up, but or someone feel free to speak out if you attended. I'm looking through the list. I know there were a few people on the sign up that did attend, but if you didn't, then hopefully I can share what I thought was one of the most important things to come out of those meetings, and that was this theme of trust. And you know, I think we all recognize and understand why trust might be a concern based on kind of what's been in the media and the news over the last year in regards to Carequality, and some folks that had some issues with each other in terms of new participants that were getting onboarded. And so it really led to a very detailed discussion of trust throughout all the network's sessions. And I think there's no question that what transpired last year, and as TEFCA and the QHINs are working closely together, they really are taking what happened to heart and working at building in new business processes and definitions to help kind of tighten the guidelines, if you will, for participation, certainly in TEFCA and potentially for the other networks, to try to help make sure that we're headed down the right road to scale and have more and more participants in nationwide data exchange, whether it's TEFCA or the other networks. Also wanted to make note, if you were not able to attend those sessions in person, they have published all of their educational sessions online. For all of you who attend, I will supply this PowerPoint out to you with the links so that you can use those links to easily get to the sessions. I do encourage you to browse through those, and because there's there were a lot of great conversations. So as part of those trust conversations, there was a lot of discussion around, in terms of eHealth Exchange and Carequality, and even hearing from some of our Commonwealth Alliance friends that an alignment with TEFCA would probably be very beneficial. And so the real question becomes, okay, to what level do the other networks align with TEFCA? And what are the key things that could potentially change? So just to, while we certainly talked about one of the motivating factors here is the issue between two implementers that caused the first ever formal dispute to get filed with Carequality. There's also, I think, other potential benefits that can come if other networks decide to adopt some of these TEFCA SOPs. And I think certainly for those of you, and I do know there's many of you on this call that are participating in multiple networks and certainly have plans to participate in TEFCA. And it can be really challenging to have different business rules and even different technical requirements for different networks. And I think it's even harder on the business side, because then as a gateway provider can kind of insulate you from some of the technical variances that when we're talking about business processes, such as what kind of information has to be provided when we register new participants into these networks, having some commonality can be very helpful. And I think for those of you who are healthcare vendors, it's very helpful because you can help properly set expectations for your customers. And for those of you who are healthcare providers, you can be more confident in the information that you're sharing with, across all the networks. So, and then the final piece I'll comment on here, and then I'll pause for some potential questions here. I think there's no question that some of the lack of clarity, and let's just pick on Carequality for a minute, in terms of what falls under treatment, for example, has led to some of the problems. And, in looking at what we're going to do is look at some of the details of these SOPs here in a few minutes. And I think you can see that they're really, instead of just referencing HIPAA, they're really trying to be very prescriptive into what constitutes required treatment, which we'll talk about here in a minute. And that filling in of the lines and removing some of the gray areas, I think is going to be really helpful, both for provider participants as well as health tech vendor participants who are onboarding customers and evaluating new potential participants to the network. I'm going to pause here. Who has any sort of kind of initial comments or input? If you attended the national meetings in December, that would be great to comment what you kind of took away from them. But also just in general, if there's a specific question you want to make sure I cover, just any sort of input right now, bring it on.
I had one, Marilee.
Go for it, Matthew.
So the whole concept of aligning with TEFCA, there's two parts to my question. One is, did any of these networks, Carequality especially, give any indication on when they would make a decision on aligning, and not just make a decision, but implement aligning?
So let me fill you in on the one that I know, which of course is Carequality, because I'm on the advisory council. So the advisory council and the steering committee are working together to assess all the TEFCA SOPs that are relevant. And they just recently went through a prioritization effort to look at specific alignment characteristics. So for example, the definition of treatment, the vetting and onboarding process, what the OBO, what used to be, what is OBO under Carequality, but is called delegates under TEFCA. So just to call out those three specific things. So they went through a prioritization process. the Carequality Advisory Council has recommended some specific high priority items to form work groups on. And those work groups then will dive into the details of each one of the relevant items and make recommendations to the steering committee as to a go forward. Carequality governance model does add time, right? It takes time to form the work groups, to have the work groups make recommendations and then get those recommendations over to the steering committee. And then the steering committee actually has the final say on what specific changes get made. And then it goes out to the community. There's a comment period. The community gets to weigh in. So it's definitely not it's this way today and it's that way tomorrow kind of scenario. And Commonwealth has a similar process. They have a community. The community, weighs in on different changes that are significant departures from, where things have been. And certainly some of these things are significant changes. I mean, the definition, creating 2 definitions of treatment, and we'll dive into that here in a minute. So for those of you who aren't aware, I can kind of dive into that in more detail. But at a high level, it's going to take some time to evaluate, make recommendations, and then get it published out to the community for comment and then adopted. I do think changes could get adopted in this calendar year, however.
Yeah, okay, that's helpful. Thank you. And then the second part is we say, harmonizing the SOPs. Does that include expanding the use cases so that, the industry could get out of kind of treatment jail?
That was an interesting discussion on our call this week, Matthew. I mean, it's definitely a priority. I think everyone's trying to figure out right now, does Carequality take that on? Does it try to do that? And how many things can it do at the same time? But there were certainly people advocating, Matthew, for an expansion of use cases. I think different people my personal one is individual access. That's my kind of one that I'm advocating for. Other people are more advocating for prepping for some things I'm going to talk about later that I'll leave for a later for further in the discussion.
Thank you.
Okay, great. Anyone else? Otherwise, I can go ahead and dive into some of the
I have a question, brief one.
Yes.
For EHR companies, do we have to be interfaced with all of this, or can we interface with TEFCA and they will do it with everyone else? What are the federal mandates regarding TEFCA? Are there any mandates? Is this a voluntary thing? Where are we here?
So it is voluntary. There's no mandates, but there has been some recommended changes to the, thou shalt share data or data blocking rules to try to be a little bit more explicit that participating in TEFCA helps protect people from, some data blocking, accusations, if you will. But I really think if we just look at what's really driving TEFCA adoption, I think the most important thing that happened in 2024 is Epic, which is really the biggest source of data that most smaller EMRs are looking to share data with. Certainly, Oracle comes into play, but I would say, if we look at our customers, it's, by far getting into access Epic facilities is the most important thing they need. And Epic did announce that they're encouraging all their hospitals to be TEFCA participants by the end of 2025. And so then the question becomes, okay, does that mean Epic facilities are going to do both? Is there a period of time they'll do Carequality and then they'll just be doing TEFCA? We don't have answers to that. Epic isn't giving explicit answers to that question. They're just saying that we're all in on TEFCA, and that has created tremendous momentum for the other EMRs. So ECW is going to be a QHIN. Some of the other EMR players, Oracle just announced they're going to be a QHIN, even though they also have a very close association with Commonwealth Alliance, which is also a QHIN. So you have this initial group of QHINs, and then you have this other wave coming. I've spoken with people at NextGen. I know they're going to be picking a QHIN to partner with. So I think that you're going to see a tremendous amount of uptake in TEFCA in 2025. And we'll just because of that, and then we'll just see it'll be interesting to see where we are a year from now. One of the things that I wanted to note, I had mentioned Epic, and for some of Zen's customers, I've already given you a little bit of a heads up on this. Epic, so under the Carequality agreement, implementers can create something called business rules. And as long as the business rules are not discriminatory, meaning they're treating everyone as they're applied in the same way, implementers have some room to do things in a certain way when it comes to, how, for example, they respond or initiate queries. And one of the big ones that has emerged here in the last quarter is that Epic has, and I'm saying essentially adopted, because I think I'm reading between the lines, and I'm in terms of our onboarding new participants for our customers and the kind of questions we're getting asked. And that is that they are essentially adopting the business rule of that the treatment that they will be, the treatment queries that they will be responding to will meet the definition of required treatment under TEFCA. So my sense is there's not a lot of gap between the normal treatment that we're doing today under Carequality and this kind of more narrow definition of required treatment under TEFCA, but there are a few places where there seem to be gaps, and those are things that I know will be discussed, for example, in Carequality, to look for where those gaps are and who might get left off the side of the road if, for example, Carequality fully aligns with the TEFCA required treatment definition. But I just wanted to kind of give everyone a heads up that, one could make the case if the largest participant in Carequality has already essentially adopted a required treatment definition. Well, if Carequality doesn't align, and effectively it has to align. This is my personal opinion. This is not the opinion of the Carequality Advisory Council, but it is a message that I'm delivering, is if, the largest provider of data is looking at required treatment as the way they are judging whether they're going to respond to or publish an endpoint in the Carequality, in the Epic Carequality directory, then essentially it's already happened by default. So that's something that I'm just giving everyone a heads up on, and kind of stay tuned on that. So what are the aspects of TEFCA that I feel are at this point most likely to be adopted or adopted in part? And certainly I can't speak to what Commonwealth Alliance and eHealth Exchange are doing, but I know that all the networks are having similar conversations internally. From a Carequality perspective, I think these things align pretty closely with some of the priorities being discussed in terms of things that the Carequality work groups need to be investigating. And so one is certainly this new definition for TEFCA required treatment. And really what they did, for those of you who aren't aware, is they took treatment and they cut it in half. And there is a regular treatment that is just the regular HIPAA, still points to HIPAA. And there is required treatment, meaning you are required to respond if someone uses this exchange purpose under TEFCA that has a more definition than just HIPAA's definition. And so, and obviously that matters, because if you're asking for data, you're really only going to get data for required response use cases or exchange purposes, because there's so few people doing any of the optional use cases, certainly in Carequality today. And I would say that's probably true under TEFCA today also. associated with, I think these two things are closely linked. TEFCA also published a new vetting requirement, which relates to reviewing, assessing, and onboarding new participants to TEFCA-based exchange. And it's the big difference is it's very prescriptive. Here's the evidence that that the QHINs need to obtain and have on file so that they can make it available for any other QHIN. In some cases, it might actually have to be submitted by the QHIN for the formal review process that happens between the QHINs. What's important for this call is that they're pretty objective. It isn't until you get into path 3, and I'm going to talk about the paths here in a minute, that the criteria, I would say, gets to be a little bit more subjective, because they're asking for written responses. And then a written response, by definition, is always going to be kind of subjectively assessed by the QHINs. And then finally, there's some more technical aspects. And it kind of relates specifically to the SAML header in the message and the directory entries, and what at a high level for us who are non-technical, I think what's important to understand is we just want to make sure in the metadata of the message itself that there's transparency in terms of who's making the query. And this is another example of something that Epic has already kind of asked people to do. And that is when we have, for example, Zen has a customer that's a health tech vendor, and then they have a customer who's a provider. In our directory entry, it is very clear that we have that chain of custody, if you will. Zen is the implementer, our tech vendor is the candidate implementer, and their customer is the provider making the queries, and those providers meet the requirements for treatment-based queries. So I think we'll continue to see some technical changes. eHealth Exchange had a new requirement that went into effect, had a November deadline. A lot of people missed it because there was some confusion on the timeline. And it also was related to the same concept, that we just want to make sure that the metadata of the messages are clearly giving visibility into these relationships. These are the TEFCA SOPs that I will be referencing today and have been referencing. So I've got links in here for those of you for later, because there's a lot of documents out there on the RCE site. So I think it's helpful to kind of zero in on the things that these would be the documents I would recommend reading first as it relates to the things that we're talking about today. So just diving into the required treatment. This is actually looking at the exchange purposes overall. So you can see all of them. You can see now there's treatment, and then there's TEFCA required treatment. You can see the code they're using. And then obviously if you're a responder, if you have to respond or not. And then they have this other interesting concept under TEFCA that responders might be able to charge fees for providing data. We'll come back to that. And you can see under TEFCA, there's quite a few already authorized exchange purposes. Not all of these are in full production, although many are being worked on very actively. I wanted to call your attention because I think certainly to get to Matthew's question about expanded use cases under Carequality, what are some of the key differences between Carequality and TEFCA today in terms of exchange purposes? Well, one of the big ones is under TEFCA, the individual access services or patient access under Carequality. Under TEFCA, it is a required. If you're making treatment queries, you have to respond under TEFCA to individual access services queries. And for those making individual access services queries, there's a pretty high bar in terms of an implementation guide that they have to follow. So those would be folks, PHR type solutions that give patients direct access to their medical record. So here's a gap, right? So that's certainly a big one that Carequality will be thinking about. The other ones that people were concerned about are these healthcare operations ones. So you can see here that there's healthcare operations overall, and then there's these items that fall underneath healthcare operations. That's where you see this HCO, HCO, HCO. That means that these four all fall underneath, or these three specific ones, care coordination, HEDIS reporting, and quality measure reporting, all fall under this overall category of healthcare operations. And you can see this little one here. In other words, it's not required today, but they're providing you more information. And the information is that per TEFCA, 18 months following the initial publication date of the healthcare operations SOP, responding nodes must respond to queries that basically align with these SOPs. So right now, we're about 13 months away from that. As far as I can tell, the operations SOP was published in August. So that's just another one to keep your eye on, because, if we can get more uptake in these other use cases, then we think that's going to help trust, because again, there's more options for people in terms of, the reasons why they're asking for data. And if people have some sort of requirement to respond, we're just really expanding, we're really making a huge difference. So we know this is where TEFCA is going. Again, the open question is, what will the other networks do in terms of, mandating a response for some of these other use cases? So what is kind of the key differences between treatment as we know it under Carequality today, that references HIPAA, and the specific language that is included in the required treatment SOP? And one of the big ones that's kind of emerged here as people started reviewing this is that there is a specific requirement that the entity be a covered entity and are one of the following types of healthcare providers. So you can see that and I've got this on 2 pages here, it's very explicit in terms of the kinds of healthcare providers. Some people were actually surprised about some of the people on this list. I know there's some folks that are questioning a laboratory, for example, as being a valid participant, but it's here. So as long as the other things hold true, they can be participants in TEFCA. But as I know that some of you know, not every provider does HIPAA transactions in the way we think of them in terms of being a covered entity under HIPAA, and so that's an interesting question. And then finally, they're very explicit here that a health plan cannot be a delegate of any QHIM participant and sub-participant, meaning when they're using the word delegate here, they're really talking about those in the Carequality world. They're really referencing the on the behalf of use case. And TEFCA has gone out of its way to try to be very explicit about how health plans can engage in exchange, and they really want them falling under one of those healthcare operations exchange purposes, as opposed to bending themselves in a pretzel to fit a treatment definition under Carequality, for example. And then they also talk about that the query needs to be in connection with or intended to inform healthcare services through either a synchronous or asynchronous interaction with a licensed individual provider. So they've already defined above what the licensed individual providers are. They're saying it could be synchronous or asynchronous. So telehealth, virtual providers are certainly in the mix here. And that's a good thing. But they also call out another area that we've seen a lot of questions about in the last several years, and that is larger batch queries. And so here in TEFCA, they are explicitly calling out if a query, so it's saying, first of all, you can do individual patient queries and support a care management and for the identification of care gaps. That's a good thing that they're calling that out explicitly. But they also say, if you're doing that, those queries can't be at a population level. If it's at a population level, it's healthcare operations. So some of those things I think are very helpful things to help clarify some of the gray area. And these are some of the things that different implementers under Carequality had differences of opinion about here over the last several years. And I'm not just referencing the dispute, just generally speaking. These are some areas that there was some lack of clarity on. And I'm not saying this clears it all up, because I don't think it does. But I think, we definitely have clarity that, making a batch query for an appointment list is fine. Making, querying for all your patients that just got assigned to you because you are, you're a participant you're a provider that's participating with a health plan, this is an area that's going to need more discussion and definition. Certainly in Carequality, and my suspicion is likely in TEFCA too, as we proceed. All right. That was a lot of information thrown at you quickly, but I would love to get your input, encourage more questions. As Matthew brought up in his question earlier, the networks are looking at all these requirements, and I've zeroed in on a couple of things that I think will be having the most impact in terms of who can participate in exchange. And I've got other things to cover, but I just wanted this is an opportunity to take a time out here and specifically talk about this required treatment definition.
Marilee, we did have a question in the chat. Olivia had asked, what would be the implications if a given network or EHR vendor would only partially align themselves with TEFCA?
Well, it's an interesting question, Olivia, because I think the real, my concern there is, what about individual implementers putting in business rules that are more closely aligned with TEFCA? And now do we have, when you onboard someone to Carequality, does that mean like, well, I can get to 80% or 60% or 50%, but I've got these business rules that I'm dealing with that are, you can't count on having access to everyone in the network, in other words. And so that's my biggest concern, if we don't align with certain things where major large implementers are already kind of going down that road, or we have to pull those larger implementers back and say, no, we think that particular business rule runs contrary to reciprocity, or, the definition of treatment that we've all agreed to under Carequality. So we need the implementer to make an adjustment. I think all of those things are to be figured out. I do think there's room for differences, however. I just think we have to think about the unintended consequences of having those differences. And one of the examples I'll use as something that I think would be important is new use cases that TEFCA isn't even contemplating, right? That maybe Carequality can be a way where those more innovative approaches to healthcare data exchange that aren't currently supported can be tested out, and individuals who, organizations that want to do that use case between the two parties, Carequality allows for that flexibility. So I think that those are good examples where, I don't think Carequality necessarily is going to be a mirror image. If it's a mirror image, it may, then one might have to ask, what's the point of Carequality still existing? And for those of you who've heard me talk about this, I think that's okay. I think ultimately, if Carequality evolves into a pure TEFCA, that's okay, because Carequality was a trust framework from the very beginning, and TEFCA is a trust framework. And so there is an open question of whether do we need Carequality 4 years from now. I think that's going to just work itself out. And I can tell you, I don't, even though I participate with some of the groups at Carequality, I have no inside information about what direction they're going. I know right now they know how much value they're providing, and as long as that value is there, the network will exist and keep delivering it. Other questions in the chat, Brian?
No, Tom did ask if this meeting recording would be published, and yes, we'll make that publicly available to anybody that joined as well.
Yes, definitely. So I'm going to answer my own question here, and Brian, interrupt me if someone pops in with a question here. On the required treatment specifically, I think that I think we are potentially leaving out a couple of kinds of providers that don't take insurance. They don't take, and if you look at the vetting requirements and the paths in more detail, and I'm going to talk about those in a minute, you'll see that that's kind of a common theme. That's one of the easiest ways to get past the vetting is to be a Medicare or Medicaid participant. But what about the concierge medicine provider group? What about the plastic surgeon who only does cosmetic? Well, I would certainly want my plastic surgeon to have my full medical history available before I undergo a surgical procedure. I certainly would want my concierge medicine provider to have access to my full medical record. So, until individual access is fully widely adopted, these questions really matter. Once individual patient access is fully adopted, well, then maybe those gaps are at least less important because the patient can be the broker, if you will, of that data. And I have gotten different input from different QHINs on my observation about covered entity. Some were kind of like, that was very purposeful. Others were like, oh, we really didn't intend to leave those folks out. So it's going to be an interesting couple months. I'm going to be kind of a dog with a bone on this question. So for those of you who know me, you can reach out and see what I've learned over the next quarter on this topic. All right, so let's talk a little bit more about the vetting process itself, and specifically the TEFCA vetting process. I do think it's super important for all Zen customers that are doing national networks with us and anyone entertaining it to read this vetting process SOP in detail. One of the things it does at the beginning of the SOP is talk about how they're going to operationalize all this vetting and what the timelines are, because obviously they were very concerned about putting a rigorous vetting process together and not having any SLAs in the mix. I think it was one of the first questions that some of my customers asked. It was like, well, how long is it going to take them to give us an answer when they're doing this vetting? And so it's very laid out. There's a rinse and repeat process that they've got established. That being said, I think, for those of you who are used to a pretty rapid onboarding in Carequality, although certainly that has slowed down, particularly with Epic's review, much higher level review of new participants that's occurred, in 2024. You're gonna have to, I think, understanding that TEFCA timeline is going to help understand how that might translate if it rolls down to, for example, Carequality, because we would have to do similar, we would have to have a similar SLA and define timeline so everyone would know what to expect in terms of how fast a new entry can get vetted and published. All right, so I think I've already mentioned that this does, most of the vetting requirements create a more objective measure of whether someone qualifies for treatment or not. And I think they're also designed to reduce the overhead for a traditional brick and mortar provider that takes insurance of some kind. I think the vetting process for those types of providers is going to be pretty easy. It's those that aren't brick and mortar or who don't take insurance that it's going to be more difficult. So again, just reinforcing, you must be a covered entity. You must participate in a federal, state, or commercial health plan or health benefits program, or there's a number that would apply, or conduct HIPAA standard transactions. That is a big question mark for me, because if you're not doing number one, and they may be doing this for other use cases or other kinds of non-traditional providers, but just be aware that this is, I'm kind of summarizing for you. At a high level, I've taken the SOP and tried to put it in as few words as possible, believe it or not. They have to have evidence that they provide healthcare services to patients through interactions with a licensed provider. Now, these can be synchronous or asynchronous. And, again, this is all kind of consistent with what we saw before in the definition of required treatment, in support of care management. You can do queries in support of care management, identify care gaps for an individual patient, and both virtual or, brick and mortar face-to-face providers are supported. So then it just depends on what's your path. What category does your provider organization fall into? So the first and the easiest are those brick and mortar providers. They have face-to-face interactions with patients, and they participate in either Medicare or Medicaid. Super, super easy. Path 2 is also for a brick and mortar provider who participate in a commercial plan. Maybe they only do commercial plans. So they don't, so the path 2, if you take Medicare or Medicaid, you're path 1. If you don't, but you take commercial plans, and again, you're brick and mortar, you fall under path 2. And for all other covered entities who deliver health services, but who aren't covered by 1 or 2, you go into path 3. And where I see the biggest bulk of the people will be providers providing telehealth or some sort of virtual care. They're not, face-to-face with a patient, but they are doing HIPAA standard transactions, because path 3 still requires that. So this just kind of summarizes and it takes another look at the vetting paths as outlined in that vetting SOP. You can see path 1, people participating in government plans. They provide there's a couple types of evidence here, type 1 and type 2. For those of you, I know many of you have done I-9s for either you filled them out as an employee or you as an employer, you've had to manage those. Same concept. There's a list of evidence that, and they're organized by type. We're going to look at those in a minute. And then you have to be able to demonstrate that they provide healthcare services, and they have an interaction between the patient. Now, the exception to that is path 1. You don't need to provide that additional evidence coming from Appendix 3 or Appendix 4 in the SOP. For path 2, you have to provide this kind of evidence called type 2 evidence. And you do have to provide some information about the healthcare services that you're providing. And you fill out something called a patient interaction attestation, which is a standard form that TEFCA has published. And then if you're path 3, primarily going to be telehealth or other virtual types of providers, you're going to need to do very similar to the path 2, except that there's a different set of questions that fall under this category, patient interaction information. The way it's written, it's a little confusing to me as to whether path 3 also needs to do the patient interaction attestation. But the attestation's pretty easy and straightforward. So if I was submitting to TEFCA or prepping for that, I would do both. If you're path 3, just to have that base covered. I'm going to pause here. I do have some additional deeper dive into what that evidence kind of looks like, but I've been talking for a while, so I want to turn it over for questions. Brian, do we have any questions in the chat?
Yeah. Matthew had a couple questions. First one, when a TEFCA response is required, does the source have to respond that they have no information if they do not have data, and or if the source has data but doesn't want to respond for some reason?
Oh, Matthew, you asked such great questions. If you don't have data, that's okay. I mean, 1, patient cannot be found, so that's a valid response. If you don't have data consistently, there's a reciprocity issue. And that there is reporting designed to look for reciprocity, and it's being discussed about in all the networks. And I know it's one of the things that Carequality looks at is, if a complaint should occur, if one implementer complains that another implementer is not doing reciprocal exchange, then that's one of the data points that an implementer would be asked to provide. So if the patient is in your system, right, if there's a patient found, you should be returning with something unless the patient has not consented to share that data. That is still a valid, the patient has the right to opt out of data sharing at any provider they see. But again, if every patient for a provider was not providing consent, then that would probably be a red flag. And I'm not going to have definitive answers in all of these, I can guarantee you. I'm just giving you my best guidance.
Okay, and the second part of Matthew's question, is there a requirement for QHINs to talk to each other? And what is the mechanism for, say, a participant in an Epic QHIN that wants data from the Commonwealth QHIN? So basically, will it be necessary to connect individually to all QHINs, or can you connect to one and have access to all of them?
You can think of the QHINs as the same thing as implementers in the Carequality world. There's just way less of them. So the QHINs are always talking to one another. So in fact, there's even rules stating you should only participate in one QHIN. So pick your QHIN. Now, there may be a little flexibility if you've got different use cases that you could have this exchange purpose in this QHIN and a different. So, that starts to get complicated pretty fast, but generally people are going to pick a QHIN, and then you will be able to access all the other QHIN participants of all the other QHINs in the same way that, you participate with Zen as an implementer and you can get access to all the other implementers' data under Carequality. That's really what makes it a trust framework. That was a great question though, because not everybody would necessarily understand that. And just always think of parent-child, right? So you've got the QHIN, you have the QHIN's, primary participants or parents' entries, and then you have all their potential children. So if you're a health information exchange, you could pick eHealth Exchange as your QHIN, or Kanza, or another, and all of your participants who also elect to participate in TEFCA-based exchange, those would all be children under a health information exchange's entry, and in the directory. Other questions? All right. We'll drop into type 1. So generally speaking, for all these different paths 1, 2, and 3, you've got type 1 evidence and you've got type 2 evidence. So at a high level, type 1 evidence relates to proving that the provider is participating in one of those federal or state health benefit programs. So what they're asking for is a link or a screenshot of the provider's entry in a host of different state or government websites. So if you look at the SOP, it has them all outlined there for you, and it's pretty easy. If they're, I'm certain if those providers were participating in Medicare or Medicaid, any of those would work. So that's pretty straightforward. Type 2 evidence, which applies to path 2 and path 3, expands that out a little bit. Number one, at the provider level, they can provide their the NPPES site, where they get the NPIs. It could be a state licensing site. Also, it could be a copy of their malpractice insurance certificate, or a private pay commercial payer participating provider link that they're showing up on, United Healthcare's website, for example. And then as a covered entity, it's really going to be focused around that payer participation and or evidence that there's other standard HIPAA transaction sets being engaged in. So that's your type 1 and type 2 evidence. In terms of providing healthcare services and this applies to path 2 and path 3, where you have to prove that you provide healthcare services. This is now where we get into our more subjective, answer some questions, put a paragraph together. For those of you who have been dealing with Carequality and Epic's questions about new entrants, these are very similar. And now Epic has now zeroed in. These are the questions if under Epic's new business role, if they want to know more about your organization, these are the questions that they will be asking. Explain the ways in which Inter provides healthcare services to patients. And then this zeroes in on how queries are going to be made. Is it a person hitting a keyboard? Is it a trigger? When does the trigger occur? If it's being done in more of a batch, what does that look like? So this is where they're really digging in and getting, a higher level of detail. And then under Appendix 4 is this validation of the interaction between the provider and the patient. How is the provider engaging with that patient? So this is, what they're trying to do here is understand if you're a telehealth provider, how's that interaction happening? And so you can see here past 2 and 3, you do this patient interaction attestation and the patient interaction information. Path 3 is where you get these questions that you answer. So if you're path 2, you just do the attestation. If you're path 3, you do answer these additional questions. All right, we have come to the end. How are we doing? Oh my gosh, perfect timing. I never time these things out ahead of time, and it's dangerous. I would love some input, comments. Doesn't have to be a question. It can just be weigh in. I'm encouraging you to let your voice be heard. That you can provide me input on any of this through email. But I do encourage you, since we know that Carequality is spinning up some work groups, now is a fantastic time for implementers to be getting feedback. And feedback can also, be routed up to the RCE and to, TEFCA. So it doesn't have to just be related to if you're a participant in Carequality. Commonwealth is also, looking at alignment and where it makes sense. So anyone have a comment? Brian, I'm going to rely on you. And actually, I'm going to stop sharing because I don't need to share anymore. So that's going to make it easier for me. Anyone who wants to speak up, you can raise your hand. I can now see you. And Brian, if you can keep an eye on the chat for me.
Sure thing.
I have a little survey then, since no one has a thought. How many of you are here because you're seriously considering TEFCA participation? Just raise your hand. I won't do a screenshot, so I won't hold you to it. No one's considering. There we go. Great. That's notable in that there isn't a lot. And that tells me that maybe we're still early on. How many of you are here because you're already participating in Carequality or another network and you want to make sure you keeping an eye on what's going on. Again, raise your hand. Great, great, awesome. I appreciate the interaction. It helps me, and I'm gonna pop over to the chat box here.
Yeah, we did get one more question in chat, Marilee.
Yes, please, go for
The
it.
question is for Epic. It's automatic that you're going to be participating, correct?
So Epic, obviously, we know is migrating people to TEFCA. So what we don't know is, will they only exclusively do TEFCA, or will they continue, will Epic facilities continue to participate in both Carequality or TEFCA? So that's number one. The other aspect of that question could be, and you're welcome to jump in and send me down the right road if I'm not interpreting your question accurately. We know that as it sits today, when we're doing new Carequality submissions, and Epic does a review, so they're doing a review of every new Carequality entry into Carequality, and they are looking at it through this lens. They're looking at it through the required treatment lens and asking questions. So what Zen is going to be doing is putting together a more comprehensive new participant entry. Right now, it's going to be a spreadsheet to gather more information from our Carequality participants, so that when we go to create a new entry in the Carequality directory, Epic isn't slowing things down, where if they are, I'm not having to come back to you and get more info. We'll already have it ready to go. So I think Epic plays a role in here in a couple different ways. But certainly they're having an influence and an impact. All right, I think we are 2 minutes. I really do appreciate. Oh, Bart, how do you raise your hand to answer the questions? Bart, just go for it. Bart, do you have a comment?
My comment was, I'm just trying to figure out how to answer your questions on the screen. And so I'm looking for that, and that's why I didn't answer one way or another. And there may be others who have the same issue.
Yeah, there's a little raise your hand at the bottom in the black bar where there's and maybe it's not for everybody, but
I don't have that in the bottom of mine. So you must have to go someplace else to do that. Like
That would
more,
make it
maybe
harder.
under more,
No,
recorded captions, Q&A, docs, notes.
There's a react button at the bottom, Bart. I just found it. I had the same problem.
Oh,
At
the
the
React,
bottom, it's
is
called
it?
React. Yeah.
Okay.
Click that.
If you had said React, I would have known where to go. I was looking for this other.
Yeah, I see
Different
options
systems,
down
and
here.
based on the system you're using, sometimes
Yeah,
a little bit different.
yeah, it absolutely can get those differences.
But you might want to take that survey again, is what I'm saying now that we all know.
Okay, we'll do it again then. How many of you using your React option are thinking about participating in TEFCA? You're right, Bart. That is a bigger list. That's awesome.
Yeah.
Any final questions or comments? And I just, again, thank you all so much for participating. We'll make the call recording available, and we'll make sure you have the presentation so that you can take advantage of those links.